Alzheimer's disease is the most common cause of dementia. On dementia patients, not all of them has Alzheimer's disease. Nowadays, there are over 70 million Americans age 64 plus living with Alzheimer's dementia. And especially the Hispanics are more affected than the white population. Interesting is that the recent approval of disease-modifying therapies for Alzheimer's disease has made precise and timely diagnostic critical for patient care. Over many, many years, we only have treatments that could, drugs that could treat symptoms. But now, finally, we see a light in the end of the tunnel. Now we have drugs that can target amyloid, that can slow disease progression. And in the light of these drugs, to have the patient eligible for this type of treatment, we need to show evidence of the presence of the amyloid in the brain to have the patient qualified for the treatment. The real challenging is because the clinical presentation does reflect neuronal function topography, neuronal dysfunction topography, but not a specific pathology. The etiologic differentiation between Alzheimer's disease and other type of dementia is unrealistic based on clinical symptoms. And when we think about the disease course, we know that the amyloid deposition and tau deposition happens many years before the symptoms starts. And even for the follow-up of this patient, for monitoring progression, the clinical evaluation has poor sensitivity. Recently, the National International Agent in Alzheimer's Association redefined Alzheimer's disease as a biologic construct. Rather than solely a clinical syndrome, the Alzheimer's disease is based on biomarker evidence of amyloidopathy, called A, tauopathy, called T, and neurodegeneration, called N. And more recently, the revised criteria for diagnosis and staging of Alzheimer's disease by the Alzheimer's Association work group reconceptualized AD as a biological process that begins with the development of Alzheimer's neuropathological changes, even in the absence of symptoms, allowing for early detection, more precise staging, and better target therapies. In this sense, PET allows definitive early diagnosis and timely intervention. On PET, we have tracers for amyloid, we have tracers for tau, and we have tracers for neurodegeneration. And a common question is, what should I use? Should I use PET or should I use fluid biomarkers, CSF or blood? On my understanding, both are complementary. The choice of the biomarkers, either PET or fluid, will depend on clinical indication. Fluid biomarkers can provide multiple information on early stages at low cost and easy or broad access if you're talking about plasma ones. But imaging can reveal extent and distribution of pathology, and depending on the tracer, you can also review patterns of disease. While fluid biomarkers is an indirect measure, it reflects activity of a dynamic process. PET has a strength with regard to validation, prediction, differential diagnosis, staging, and therapy. In fact, combining imaging fluid biomarkers is what show promise. Talking about PET imaging, we have 3 tracers approved by FDA: that are very similar, that will provide direct, non-invasive detection of amyloid plaque pathology in the brain. The clinical role of PET amyloid is to exclude or support the diagnosis of Alzheimer's disease. The main scenarios are for the detection of atypical forms of Alzheimer's disease, or for identification of cases clinically appearing like Alzheimer's disease, but based on a different pathology. And it's increasingly get more important in the approval of disease-modifying therapies, for the patient selection for therapeutic approaches or for assessing treatment response. Very recently, June this year, there was a new expanded FDA indication for amyloid PET for quantitative measurement of amyloid plaque, used for therapy monitoring and for predicting cognitive decline. If you, I'm not going to enter into detail, but there was a very good publication by the Alzheimer's Association and Society of Nuclear Medicine and Molecular Imaging that update the criteria for amyloid and tau PET indication that you can refer to later on. But I wanted to get what information we can get for the amyloid PET. So first here, this is a positive scan where we see deposition of beta amyloid in the cortex of the brain. And here we have a negative that we don't see amyloid on the cortical region, but we just see in a specific uptake in the white matter. So whenever we see a positive scan, it means that there is significant A-beta deposition in the brain, as you see in the cortex. And when there is a negative scan, there is no or low density A-beta deposition in the brain. When we have a negative PET, we can tell that the finding is inconsistent with Alzheimer's disease. If the patient has dementia, it's not related to Alzheimer's, because to be the hallmark of the pathology is amyloid and tau. If you don't have amyloid, this cannot be Alzheimer's disease. In the other hand, if you have a positive PET, you can confirm the presence of neuropathology. But this finding is insufficient to make the AD diagnosis isolated. It requires clinical or other biomarker information. We have to keep in mind that there's also other disease that can show amyloid deposition, such as amyloid angiopathy or other type of dementias, or even situations where Alzheimer's is a co-pathology. But interesting that in patients with mild cognitive impairment, the positive finding on the PET imaging represents an increased risk of Alzheimer's disease conversion. Just to explain, patients with mild cognitive impairment are pre-dementia patients who have cognitive impairment compared to the people with the same age, but the impairment doesn't affect their daily living activities. A positive amyloid PET with a typical clinical presentation or biomarkers is highly reliable diagnosis of Alzheimer's disease. And by identifying the amyloid status, we can help differentiate the various types of dementia syndromes, such as frontotemporal dementias that never shows amyloid positivity, or atypical Parkinsonian syndromes such as progressive nuclear palsy or multisystem atrophy. The criteria for reading this PET is just dichotomic, as negative or positive, but we know that the uptake, it's a continuous thing. So in order to facilitate that, quantification, it's a good option. Initially, the centiloid scale was built to standardize quantification between different tracers in multicenter studies. But it was a good way that to actually scale to quantify the amount of AD pathology on the brain. So we started to bring these values into clinical value as well. For example, a patient with centiloid scale 10 and below is going to be negative. A patient with centiloid scale over 30 is considered positive. And the ones in between are the intermediate range, where we can kind of predict amyloid accumulation or progression to dementia. This quantification certainly improves reader confidence, inter-reader agreement, but in fact it promotes accurate determination of A-beta status, which is critical for treatment decisions. We have been increasingly seeing this quantification being adopted as a standardized metric for target engagement in monitoring anti-amyloid therapies. And visually assessing, particularly because visually assessing amyloid clearance is difficult in cases where we don't have a complete removal of amyloid of the PET, what we call the partial treatment-related amyloid reduction. Talking about therapy, we cannot forget to talk about the complications of the treatment. Patients need to be followed. There is a risk of developing amyloid-related imaging abnormalities called ARIA, and these patients should be followed with MRI. More strength fields better, and read by a neurology would be the ideal. The PET tracers that targets tau are not as available as amyloid, but we have one drug approved. It's going to take longer to be adopted in the market as a clinical practice, but a positive tau has good value. Tau is associated with cognitive performance, differently from the amyloid, and correlates with disease stage and clinical progression. These traces are still not ideal. The FDA approved flutarcipir this is the one that is approved. Newer products are supposed to come shortly to the market, but still they cannot differentiate between 3 repeats and 4 repeats on the tau forms, and they have lower accuracy for identifying very early Braak stages below 4. The sensitivity and specificity is above 90% in differentiating Alzheimer's disease from other neurodegenerative diseases, and predicts future rates of cognitive decline across the Alzheimer's disease clinical spectrum. And it's been used to inform about anti-amyloid response in drug trials. When we talk about the neurodegeneration, here I want to call into attention that we have FDG. We have FDG here in Puerto Rico, and we should take more advantage of this methodology. Some people, I learned yesterday, some people still use PET-CT, but there is no comparison between PET and SPECT. The spatial resolution is much, much higher. We can see things that we cannot see with SPECT. The only situation that we should do SPECT is whenever there's no PET available. And the beauty of FDG PET, as we have now with FDG, is that FDG measures glucose metabolism, which reflects neuronal activity. So we can show areas where there is abnormal activity. And many people don't know, but FDG PET, as the one you have here, is an independent biomarker to predict Alzheimer conversion in patients with mild cognitive impairment, independent of hippocampal volume or amyloid PET status. The FDG PET imaging reveals disease-specific patterns of glucose hypometabolism. And because of this difference between the hypometabolism, the regions that are affected, we can differentiate Alzheimer's disease from frontotemporal lobe degeneration from dementias with Lewy body. And we can predict which patients with mild cognitive impairment that will progress to Alzheimer's disease. More recently, a new pathology was described called LATE. The name is very complicated. Limbic predominant age-related TDP-43 encephalopathy. It affects more older people than Alzheimer's disease, and we don't have, and the course of disease is more prolonged than Alzheimer's disease, but we don't have any tracers that we can image it. And FDG has shown specific patterns that we can identify in these patients without histopathology. Additionally, PET can help distinguish in other forms, distinguish neurodegenerative disease from non-degenerative cause of cognitive impairment, such as traumatic brain injury, idiopathic normal pressure hydrocephalus, and depression. So summarizing what we have with PET. When we talk about neurodegeneration, the FDG show characteristic metabolic patterns in different types of neuropathology. We can differentiate Alzheimer's disease from frontotemporal disease and dementia of Lewy body. And we can differentiate the patients with mild cognitive impairment that will progress to our AD. With amyloid PET, we can confirm the presence of amyloid pathology. And on the patients that are negative, we can certainly affirm that this patient doesn't have Alzheimer's disease. And amyloid positivity in a patient with mild cognitive impairment represent increased risk for conversion to Alzheimer's disease. With tau PET, we can confirm that it's tau deposition in the brain. And this deposition, the way it feels in the brain, is associated with cognitive performance and correlates with disease stage and clinical progression. So I would like to show one case of a 68-year-old female patient with memory deficit starting 12 months ago, MoCA score of 23, a positive family history for dementia, and an MRI with no significant abnormalities. This is the FDG study. I know most of you are not immunologists or nuclear medicine physicians. In these patients, it's hard to see if you're not well trained, but we do have some alterations here on the posterior parietal, cingulate, gyrus, some mild reduction on the frontal lobe as well, but we do have preserved the activity in occipital cortex, on visual cortex, and on striatum and cerebellum. This pattern can be best observed when we use quantification, that we have a 3D representation. And what I describe is what matches a mild pattern of Alzheimer's disease. So this patient also had an amyloid PET, which we confirm a diffuse deposition of amyloid through the brain, and also tau pathology. what we could characterize through ATN of being an Alzheimer's disease. And as I mentioned before, we are on the era of precision imaging. We are in the era of empowered decisions. We need to do diagnosis, especially in dementia, as early as possible if we're thinking about this type of treatment. And not all people are equal. Not all PET-CT is equal. Having a better resolution does matter. Look at an old version of PET-CT era with a current era, the resolution is much better. And especially when we talk about amyloid, this is very, very important. In patients with atrophy, the cortical rim is very thin, and if you don't have a very high resolution PET, you cannot distinguish what is white matter and what is the cortical uptake. So you can easily interpret as positive situations where you don't have real uptake in the cortex due to the very thinning and the spill off of the activity from a lower resolution equipment. And if you're talking about dementia, demented patients, motion correction is also very important. These patients don't understand, and they move, and the images are severely degraded by movement. Interpretation is severely compromised. So it's important to have motion correction, effective one, so you can have a right interpretation of the exam. And this is another case of a 68-year-old female with a long history, 5-year history of progressive cognitive decline. More recently, she developed mutism, aggressive outburst, urinary fecal incontinence. And she also had a family history with mother with dementia. She has been treated with memantine and donazepam with minimal response. This is an FDG finding, very, very abnormal, just to show you there's a high diminished metabolism in the frontal lobes, in the parietal lobes as well, temporal lobes. We do have some decrease here on the striatum, majorly on the left side, major reduction in temporal lobes, visual cortex is preserved. So we do have frontal and posterior involvement. Sometimes if the patient has a very advanced dementia, can be hard to distinguish between one etiology to another one. So could be something more related to frontotemporal dementia. And the patient was submitted to amyloid PET, which was negative. We could see it because of the high resolution, and we could confirm that this patient did not have Alzheimer's disease, most likely frontotemporal disease, maybe PPA. So advancing beyond clinical symptoms, PET imaging now plays a key role on Alzheimer's disease diagnosis by identifying biomarkers that biologically distinguish Alzheimer's disease from atypical dementias and other neurodegenerative disorders. The ability to detect and track neuropathology in vivo with precise localization enables early diagnosis, more target treatment decisions, and real-time monitoring of therapy response. PET scans illuminate the invisible, revealing the hidden terrain of disease that symptoms alone could never map. Thank you very much.
Initializing scan.